Hello and welcome to Chapter 13 Lecture Part 2, all about obstetrics. Obstetrics being specifically the knowledge or practice of pregnancy and childbirth. I forgot to do a term of the day for the first part of the chapter, but for the second part of the chapter, I do have a term of the day. And it is all about it's really, I guess it's not really a term, it's just a little trivia or some information about twins, about what twins are. So there are different types of twins. It was originally thought that there were only two types of twins, that there were fraternal twins and identical twins, also known as dizygotic or monozygotic, because fraternal twins come from two different zygotes. So when you have an egg and it gets fertilized, usually then it develops into a fetus. Now, in the case of dizygotic twins, when the sperm and the egg meet, that is called, and it becomes fertilized, a fertilized egg is known as a zygote. So if you have two separate zygotes, two separate eggs that are fertilized by two separate sperm and then develop in utero together, those are dizygotic twins or fraternal twins, which are really just two siblings that happen to be born and grew up together at the same time, as opposed to several months apart. But genetically, they're related just as much as two siblings of different ages. Identical twins are when you have one zygote, one egg fertilized by one sperm, and then during the normal development of the zygote, it goes through several stages of cleavage. The egg splits into 2 and then into 4 and 8, so on and so forth. When it splits into 2, if those two cells accidentally separate and then develop into two different fetuses, then you have identical or monozygotic twins. They came from one zygote. Now, recently, it's been with the advent of genetics and technology and bioinformatics, it is very rare, but there are cases of semi-identical twins where there was one egg and there were two sperm. Now, the process of fertilization is very heavily regulated, and one egg technically cannot be fertilized by one sperm, or by more than one sperm. So this sort of idea was, what's the word? People were skeptical about the existence of semi-identical twins. But it's been genetically shown where you have two twins who have the same maternal DNA but different paternal DNA. So it's a little, I guess, more in-depth biology is that mature ova there's the main body of the egg, but then there's also this separate little body that does contain a nucleus that kind of deteriorates after fertilization. But it's thought that if that little separate body gets fertilized by a sperm, it too can develop into a fetus. So this is a picture actually of my dad and my uncle Scott. They are twins, and their mom has always argued that the doctor told her that they were semi-identical. I don't have the results of the genetic testing, and I'm dying for them to go through it because I'd really like to know if it's true or not. They do look an awful lot alike and have awful lot of similarities, but they are not identical. So yes, one of these days I'm going to make them get tested, but we'll see. So sexual maturity begins at puberty. Sorry, closing my window. And it starts when there's secretion of certain hormones from the pituitary gland. Now, these hormones might sound familiar because they're also the same hormones that the male pituitary gland secretes to stimulate male sexual maturity. And those two hormones are follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. I don't know if anyone's figured it out yet, what this picture is doing on this slide, but it stems from a corny joke. And the joke is, what do you call a fish with no eyes? A fish. Get it? FSH. Fish with no eyes. Okay. So the follicle stimulating hormone helps to stimulate the follicles in the ovary to mature and produce an egg, whereas luteinizing hormone stimulates the ovaries to start producing hormones, the three major sexual hormones. Estradiol, which literally means female sex hormone. So estra means female, and then diol is actually a chemistry term, meaning that it has two alcohol groups. So it's talking about the chemical structure. So estradiol, which is closely related to estrogen, progesterone, which is the pregnancy hormone, all right, pro, meaning before, and gestero, like gestation, pregnancy, or conception. Now I gotta look that up. Gestation. Gestation means pregnancy, so I guess gestero can mean conception or pregnancy. Testosterone is also produced by the ovaries. It's named after the testes, where it's produced in abundance, but the ovaries also produce a small amount of testosterone as well. So those three hormones together work to promote the sexual maturation and the different signs of puberty. So the estrogen causes hair growth in certain areas in the pubic region and the axillary region, the armpits. Breast development stimulates ovulation and menstruation. Stimulates a widening of the pelvis, of the hips, so then you get a narrower waist and wider hips. Testosterone helps to stimulate sex drive. I think I got most of these. Development of the external genitalia. They grow slightly, just like men do. So at puberty, females start menstruating. They start ovulating, so releasing an egg every month. And then if the egg does not get fertilized, they shed their endometrial lining, known as the period or menses. So this is what the menstrual cycle looks like. I like this chart because it goes through, it actually has a lot of information. It shows you what happens through the menstrual cycle in the ovary. Then it tells you also what's happening with the hormones and with your basal body temperature, and also what's happening within the uterus at each of these different points in the cycle. So a typical menstrual cycle is 28 days, plus or minus a few. It varies in different women. So what happens? The first stage of the menstrual cycle is the menstrual phase. Day one of your period is day one of the menstrual cycle. So that is the part where the endometrium sheds itself. This is where in your ovary, a new ovum, a new follicle that contains an ovum, starts to mature, starts to get that ovum ready to be released and to be fertilized. So it starts developing. One of the things that helps it develop is estrogen, estradiol, okay, which is increasing over the course of, really after the first week, it starts increasing in the second week as the follicle starts to develop. When the follicle is mature at the end of the second week, you get ovulation. So the follicle ruptures and releases that ovum. When ovulation occurs, there's a dip in the estradiol production, and progesterone production actually starts to occur. The body starts to prepare for the possibility that that egg gets fertilized and that you get knocked up, I guess is the way to put it. Also, in response to ovulation, the basal body temperature increases just a bit. And as you can see here in the uterus, in the endometrium, after ovulation, the uterine lining starts to thicken a little bit. We have the secretory phase, the uterine lining already starts to thicken after it's shed in the first week. In the second week, it starts to thicken itself again. It's the proliferative phase. And then in the third week of the cycle, after ovulation, the uterus continues to thicken, the endometrial lining continues to thicken, and also starts to secrete mucus and stuff that helps the potentially fertilized egg to implant. During the third week, you also get steady progesterone production in the hopes that you are going to become pregnant. And in the ovary, what's going on is that ruptured follicle starts to degrade and deteriorate. And in fact, it's that ruptured follicle that's producing all this progesterone. So as the ruptured follicle sort of starts to involute on itself, it turns into this yellow fatty thing called a corpus luteum. And then as that deteriorates, it turns into this little white, the final sort of stage of its life is this white, the white body is what it's called, corpus albicans. And in that last phase, if implantation fails to occur, as the corpus luteum dies and becomes the corpus albicans, progesterone production stops. And that is the signal for the ischemic phase of the menstrual cycle, the phase where the endometrial lining dies, it necroses, and leading to the shedding of the endometrial lining again at the beginning of the next menstrual cycle. So that is the menstrual cycle. The first period that a girl has is referred to as menarche. Menarche is the first period, and periods, the medical term for periods, are menses. So conception is when sperm meets egg, and the egg gets fertilized and becomes a zygote. So each gamete, so ova and sperm are both gametes. They are both what we call haploid cells. They contain one set of 23 chromosomes. As humans, we have two sets. Like an adult has two sets of chromosomes, of 23 chromosomes, for a total of 46 chromosomes. The egg and the sperm each carry their own 23, and then when they fuse, they form a zygote that now has 46 chromosomes. One set from the dad, one set from the mom. And conception, or fertilization, is the start of pregnancy. Hopefully, assuming that the egg then I guess it's technically the start of pregnancy. So then the egg actually has to travel down. So fertilization actually occurs in the fallopian tubes. As the egg is moving down into the uterus, the sperm actually swim up the fallopian tubes to fertilize the egg, and then it starts dividing as it's moving down towards the uterus. So you can see here the dividing process, first into 2, then 4, then 8, etc., until that it forms this blastocyst structure, okay, where there are cells around the outside, and then there's a cluster of cells on the inside here, and then there's a big space, the blastocyst cavity. And this inner cell mass here, the pink cells, that is what becomes the embryo. That is what becomes the amnion, all right? This outer cell lining is the trophoblast. You don't need to know that. And that's what becomes the chorion and the placenta, the tissue that sort of attaches itself to the uterus and then serves to sort of feed and nourish the developing fetus. So starting at this stage already, just after a handful of divisions, the chorion starts to develop and starts producing human chorionic gonadotropin, or HCG. This is the hormone that you look for in a pregnancy test, whether it be a urine pregnancy test or a blood pregnancy test. HCG is what you're testing for, the production of human chorionic gonadotropin by this early stage embryo, as soon as 2 weeks or sometimes even less after fertilization. So gestation is really like a medical term for pregnancy, the time from conception to birth. So gestation lasts in humans approximately 38 to 42 weeks, and it's divided into 3 trimesters, which I don't have a timeline for you, but I do in the next slide, kind of overview of what each trimester can, the major events of each trimester. During that time, the fetus, I guess, goes by a couple of different names as well. So initially, a fertilized egg is referred to as a zygote. And then after it starts dividing, we refer to it, I guess it technically goes through a couple of other stages like the blastocyst. And then it becomes the embryo. And then I think around 8 weeks or so, 8 or 9 weeks, once it actually has most of the basic body parts, limbs and head, and all these things have started to develop, we start referring to it as the fetus. And I don't know if this is medically established or ethically established or what. That's another discussion for another time. But some terminology here. When we're talking about pregnancy or gestation, that period is referred to as the prenatal period for the fetus, but the antepartum period for the mother. So ante, again, meaning before. So antepartum, just like anteflexion, means before. Antebellum, I'm from the South, so that's a term I'm familiar with, means before the Civil War. And again, uses this ante prefix. Okay, so antepartum, before birth for the mother, and prenatal, before birth for the fetus. So the 3 trimesters shown here. First trimester, about the first 12 weeks or so of pregnancy. A lot happens actually. You can see here this small little peanut of a fetus, but it already has head, limbs, all of the basic organs form during the first trimester. The first trimester is when the fetus is most, or the developing embryo, I should say, is most sensitive to teratogens or chemicals that cause birth defects. The second trimester, a lot of lengthening growth occurs. The organs start to mature, the bones start to harden. And then in the third trimester, it's mostly the organs maturing and the fetus putting on a lot of fat, gaining a lot of fat. And of course positioning itself hopefully positioning itself properly for labor. Alright, so in the third trimester, a few things, physiological things start to happen. One thing that occurs during the third trimester is women start to experience Braxton Hicks contractions, also known as false labor. These are essentially contractions of the uterus that basically the uterus is starting to get a little early workout, trying to warm up for the process of labor. It's like a warm-up. Engagement is when the fetus positions itself and drops into its birth position. So the proper position for birth is with the head down, called cephalic presentation. Okay, typically the ideal presentation is with the top of the head pointing towards the cervix. That's called vertex presentation. Okay, and that's ideal with the infant facing posteriorly with the tip of the head at the opening of the cervix. And we'll talk about some other positions that the fetus can take that are not ideal. But once, the third trimester ends obviously at labor. But labor is typically a long process, and it's divided into 3 parts. And the medical term for labor, by the way, is parturition. So there's 3 stages of labor. The first stage is when the cervix dilates, where you get cervical dilation and effacement, which is the, here we go. So here you can see the vagina and the cervix, and this is normal looking, what it looks like throughout pregnancy. But during labor, you need to sort of push all of that aside, do away with it so that there's room for the baby to actually come out. So dilation and effacement is essentially the sort of the disintegration of the cervix, or the pushing back of the cervical membrane so that there's room for the head to push through. And also rupture of membranes is considered part of the first stage of labor. That is when the amniotic sac ruptures or bursts. So I guess that happens in between these two steps, because here you can see there's still a sac, an amniotic sac around the baby, whereas here it looks like not, and there's fluid in there. Here it looks like probably not so much. It looks like there's already been a rupture of the membranes. There's no membrane around the fetus anymore. There's just his head coming out of the vagina. So that all is part of the first stage of labor. The second stage of, and that's the longest stage of labor. Some women, it can last for several hours, sometimes days. But I think the average first stage of labor is about 12 hours on average, plus or minus. The second stage of labor is actually the delivery of the fetus. So it's from crowning until the delivery of the fetus when the umbilical cord is cut. So here's crowning as the head starts to make its way out of the vagina, and then delivery of the fetus, and what's left behind. So the umbilical cord kind of comes out, you cut it, clamp it, and then the placenta is left behind, but it is not permanently left behind. It is only temporarily left behind, because the third stage of labor is actually the delivery of the placenta, which usually occurs within a few minutes after giving birth to or delivering the fetus, or the baby, I guess it's referred to after birth. So again, with the terminology, the period after birth for the infant is referred to as the postnatal period, and for the mother it's referred to as the postpartum period. Think of postpartum depression, which is a common phenomenon that occurs after giving birth in women, and is largely due to the crazy amount of hormones that are still flowing through a woman after giving birth. So nato and parto are synonyms for birth, just to point that out. Postnatal and postpartum technically have the same meaning, just one is used usually in reference to the fetus or the infant, and the other is used in reference to the mother. Okay, so a little bit about the newborn. A full-term infant is considered between 38 and 42 weeks. Actually, I think they may have knocked the number down to 37 weeks, between 37 and 42 weeks. If you are born before 37 weeks, the baby is considered premature or preterm. And I guess the time period there is between 28 to 37 weeks. So anything before 28 weeks is not likely to survive, but 28 weeks and beyond, there are some decent chances of survival, let's put it that way. The chance of survival increase. And you can still have a healthy preterm labor. So when the infant comes out, it's covered in, it's going to be covered in all kinds of secretions, but one of the things that it's covered in is this like cheesy, mucusy, lotiony stuff called vernix caseosa, which literally means cheesy varnish in Latin. And that's what it looks like. It looks like they're covered in some kind of, cream cheese or something. And it serves as a lubricant for their skin while in utero, floating around in the amniotic fluid, and also helps lubricate during labor, during the birthing process. And also, after they're born, helps to keep some warmth in, keep them slightly insulated as they warm up. So in newborns that are birthed vaginally, a lot of times their heads have this funny shape, this elongation shape called molding, which is temporary, it goes away, but it's from actually physically squeezing through this narrow birth canal. C-section babies are often referred to as being prettier because they have nice round heads because they didn't have to squeeze through the birth canal. The fontanelle we talked about in the chapter 9 with bones. Remember, the bones of the cranium are not fused together yet. They have this soft tissue in between them that sort of holds them together but allows for compression during birth and also for growth of the brain. So that's why babies have a soft spot on the top of their head. It's where the fontanelle is. That's why I just remember having a lot of baby cousins and always told not to touch their soft spot. Again, because their brain is right under it. It's sensitive, so you do want to be careful. Another common condition is acrocyanosis, where the baby's extremities are blue, cyano, blue, and acro meaning limbs or, like appendages. So like feet and hands can be kind of blue. They also can have blue lips. The first stool that is produced by an infant is referred to as meconium. It's this like blackish, greenish, it's really sticky and nasty, and it has to do with the fact that the only thing they've been eating for the last however many months in utero is amniotic fluid. They've been eating, they basically eat amniotic fluid, and so and then also a little bit of breast milk, the colostrum, which is the first breast milk that comes out of the breast. It's very thick and very nutritious. So that colostrum also has a laxative effect, which helps them to produce this meconium. So the meconium has this interesting and unique kind of texture because of the unique diet of a developing fetus and a newborn. And then the stools change as they get used to a breast milk diet, and then they change again after they start eating solid foods. So some diseases and conditions of the reproductive physiology, I guess, of reproduction. You can have different menstrual disorders. So in some ways I feel like anovulation maybe belonged on this slide, but these are all specifically for menstruating, so your menses affecting your period. Amenorrhea is a condition without menses, without your monthly flow. Someone who's not getting their period, whether it be because of some kind of hormonal imbalance or because a common reason is malnutrition or eating disorder. People who work out excessively. I would bet money that none of the female Olympic gymnasts get their periods. They probably have amenorrhea. So they have very strict exercise regimens and probably strict diets. It's common in that sport, that field. Dysmenorrhea is painful or abnormal flow. So someone who gets very, very painful cramping during their period would have dysmenorrhea. Menopause is the cessation of periods after, as the ovaries stop producing the same amount of hormones, usually somewhere in your 50s, menopause occurs. And it's a normal physiological shutdown of reproduction. Menorrhagia would be excessive menstrual flow, so having very heavy periods. And oligomenorrhea would be the opposite, having very light flow periods. Oligo meaning scanty or few, right? Some conditions of pregnancy and labor and delivery. So I don't know why I'm starting here with labor and delivery, but there can be some conditions affecting the presentation of the fetus before labor. So malpresentation is a term that means bad presentation. So we talked about vertex presentation or cephalic presentation being the ideal, where the head is pointing down. And if the head is not pointing down, if the baby's positioned in another way, there can be complications. It's more difficult and more risky for both the fetus and the mother. So if the baby is breech, that means that the butt is facing downwards. You can have, there's different breech positions. You can have the head superior and the rear is inferior, but you can have a leg sticking down. You can have two legs sticking. There's different breech presentations, but either way, the head is not sticking down. And one of the complications with breech presentations is the potential for a prolapsed cord, where essentially the cord comes out first, and it can become pinched off and can stop. And until the baby is delivered, until the fetus is delivered and the cord is cut, they are still getting their blood flow and their oxygen from the mother's blood until they come out and breathe their first breath. They are requiring on blood flow through that umbilical cord to get their oxygen. So if that umbilical cord becomes pinched off and when it's prolapsed, that can be very dangerous for the baby. Transverse lie is another positioning of the baby where they're laying sideways. So some of these different types of positioning can be manually fixed, actually by pushing on the stomach. Usually not during labor. This usually occurs, a week or so before, a week or a couple weeks before labor. It's called version, turning of the baby within the uterus. Sometimes it works, sometimes it doesn't. But nowadays, with the advent of C-sections or cesarean sections, which we'll get to in a future slide, any malpresentation is usually scheduled for a cesarean section, since they are much lower. The surgery is much lower risk than doing a pregnancy, trying to do a natural birth this way. Some other conditions: cephalopelvic disproportion, or CPD. This is where the infant's head, the fetus's head, is actually too big to fit through the pelvic opening of the mother. And the pelvic opening actually does do a bit of stretching. Remember, there's this pubic symphysis here, this slightly movable joint, so the pelvis actually can stretch out a little bit during birth. But if the fetus has an extra large head and the woman has an extra small pelvis, it is possible that the fetus will not fit through that opening. And there have actually been I don't know if fossil is the right word, but bones, skeletons found where it's like a woman's pelvis with a fetal skull stuck in it, lodged in it, from women who died in childbirth before modern technology and surgical techniques. This was a real danger, Dystocia is a condition of painful labor, which kind of just, I think, makes me laugh, because what labor isn't painful, right? But dystocia would be extremely painful labor, I think, indicating some other, some condition like cephalopelvic disproportion, or I read a book about a midwife, and it told about all these stories of different labors she attended, but included her own labor. And I think for one of her children, maybe the first one, the way that the baby was positioned, he actually broke her tailbone on the way out. So I imagine that would have qualified for dystocia. Hyperemesis gravidarum. I used to think that this was just a fancy medical term for morning sickness. Excessive vomiting during pregnancy is literally what it translates to. Hyperemesis. Emesis means vomit. But I think that it means excessive morning sickness. So having a little bit of nausea would be morning sickness. But if you have so much nausea that you're constantly throwing up and you can't keep any food down, that would be severe morning sickness, or hyperemesis gravidarum. Some different types of pregnancy mishaps that can occur. Basically, two situations where you'll test positive for pregnancy, but then the pregnancy doesn't actually continue to full term because two different reasons. So hydatiform mole is kind of weird. It's where the egg gets fertilized and then goes and implants in the uterus, but it doesn't divide properly and it doesn't develop properly. So the cells start dividing, but they're not differentiating or something, and so you end up with like this large tumor or mass that was the fertilized egg, and that should be an embryo, but instead is just a mass of a bunch of cells that are not an embryo. But they do still produce human chorionic gonadotropin, and they do still cause you to have a positive pregnancy test. So a lot of times this type of pregnancy, also referred to as a molar pregnancy, because it's called a hydatiform mole. So a molar pregnancy looks like this. Usually is not discovered until the first ultrasound or the first time that when they're looking for the doctor's looking for a heartbeat, and there's no heartbeat. And then they realize that it wasn't actually a fetus. So, an ectopic pregnancy is another type of pregnancy mishap where the sperm and egg meet and get fertilized. And remember I said that happens in the fallopian tubes. The sperm actually swim up to meet the egg as it's coming down the fallopian tube, gets fertilized, and then if the egg, what's supposed to happen is the fertilized egg is supposed to keep traveling and land in the uterus where it implants. But sometimes it can implant abnormally in the uterine tube. Now the uterine tube is very, very small little tube. It's not made to stretch and grow with a developing baby. So usually this type of pregnancy is discovered early on in the first trimester, several weeks after fertilization, because there's a lot of pain. Usually it's associated with a lot of pain. You go in and they find that the fetus is developing in the uterine tube, and usually then they have to cut it out. In fact, I have an aunt who had first time she got pregnant, she had ectopic pregnancy in one fallopian tube, so they had to go in and cut out that pregnancy, so then she didn't have a fallopian tube on one side. She still had the ovary, but the fallopian tube wasn't there. So then they tried again, got pregnant again, and implanted in the other fallopian tube. So she had two ectopic pregnancies. I don't know, her fallopian tubes were really sticky or something, and just those eggs just stuck right to them. So she had both of her fallopian tubes removed, and then she and my uncle ended up doing in vitro fertilization, where they harvested her eggs and they harvested his sperm and mixed them together in a dish, and then implanted the fertilized eggs manually, for the zygotes manually into her uterus, and she had two boys. They are like 12 and 13 now, so it was very successful, but I think very painful and emotional process to go through two ectopic pregnancies and not be able to conceive naturally. Some conditions that can be dangerous during pregnancy that affect the pregnancy. Some conditions that affect amniotic fluid production. So it's important for the developing fetus to be surrounded by amniotic fluid. It is what they eat. Provides some sort of nutrients. It also provides lubrication and cushioning. So if a woman is not producing enough amniotic fluid, that can be a problem, and that's called oligohydramnios. Producing a lot of amniotic fluid is polyhydramnios. Actually, I should look that up, because I think also it has to do with how much the infant actually is taking in. Be right back. Shouldn't say infant, like I should say fetus. So like I said, the fetus actually has to, that's basically what they're eating or swallowing while in utero. So, nope. I see. Oligohydramnios. The fetus swallows amniotic fluid but does not excrete a similar volume because of a congenital abnormality of the kidneys. So oligohydramnios can actually be a sign that there's something wrong with the fetal kidneys. It's not necessarily that because the mom is not producing enough. Polyhydramnios is just simply a situation where the woman is producing a lot of amniotic fluid, and it can, I guess, signal abnormalities in the fetus as well, maybe because the fetus is not ingesting enough of it. So those are conditions that affect amniotic fluid levels. Preeclampsia and gestational diabetes are conditions in the mother. So preeclampsia is technically just hypertension or high blood pressure during pregnancy. It's also characterized by a couple of things, by high protein in the urine is one, and high blood pressure. Those are the two major symptoms. Also usually accompanied by swelling in the hands, a little fluid retention in the hands and feet. It literally means condition before seizures, preeclampsia. Eclampsia is a condition of seizures during pregnancy. It's extremely dangerous, both to mother and fetus. So preeclampsia is sort of the state that is before eclampsia, and doctors really monitor this carefully and make sure that women are not preeclamptic, and if they are, that they deal with that. They treat it, try to get the blood pressure down, treat the high blood pressure. Gestational diabetes, technically gestational diabetes mellitus, is diabetes that specifically develops during pregnancy. It's not really well understood why. Occurs in women who do not have diabetes already. They suddenly develop diabetes during pregnancy, usually around the second or third trimester, and then it goes away almost immediately after giving birth. So it has something to do with the changes, hormonal changes, and the effects of hormones on the glucose regulation. So gestational diabetes can be, the major side effects are that it can cause you to have the baby to be large, the fetus to be large. Often a woman who has gestational diabetes, the fetus is more likely to develop diabetes in life, etc. Also, there's the added risks of diabetes, namely low blood glucose levels or high blood glucose levels, which have their own side effects. There are also conditions where the placenta, something is wrong with the placenta during labor. So the placenta ideally is going to be located somewhere up here, somewhere on a wall of the uterus that's far away from the cervix. If the placenta is covering, if part of the placenta is over the opening of the cervix, then you can get hemorrhaging. You can get hemorrhaging, and that's not good. Placenta, so that abnormal positioning of the placenta is referred to as placenta previa. And like I said, it can cause hemorrhaging, it can cause bleeding, particularly during the cervical effacement and dilation, but sometimes even before that. So that's why if you are pregnant and you experience bleeding, you should call your doctor right away because they need to check that the placenta is okay and the placenta is intact. Because again, the placenta feeds the fetus, feeds it blood, nutrients, oxygen, all of those things. So it's kind of important. Postpartum hemorrhaging is another type of bleeding that is after you labor, after you give birth. From the trauma of it, it can lead to hemorrhaging that can be dangerous and threaten the life of the mother. And luckily in hospital setting, there are drugs that can help prevent that, or blood transfusions, whatever is needed. Premature labor is is always risky and is usually initiated with premature. So there's going into premature labor, as in starting contractions too early, and then oftentimes there are drugs that can counter that can stop the contractions and allow you to incubate a little bit longer. But if you have premature rupture of membranes, so your water breaks at 30 weeks, which is much sooner than full term. Full term is 37 or 38 weeks. If your water breaks or there's rupture of the membranes, then you're in labor, and that's premature rupture of membranes. Different types of miscarriage, I guess. So there's the term abortion is usually we think abortion as an elective procedure, but it is a medical term for the loss of a pregnancy. So spontaneous abortion is the medical term for miscarriage, for when the baby or the fetus just dies unexpectedly with oftentimes no explanation. And usually like 80% of miscarriages occur in the first trimester before 14 weeks, and usually they're due to some kind of chromosomal genetic anomaly that the fetus just was not developing healthily or normally. There's also therapeutic abortion, which is elective abortion. That's, I guess, the abortion that people associate, the definition people associate with the word abortion is a therapeutic abortion, which is elective. Dilation and curettage, a DNC, or also known as a DNC, mostly people talk, this is an abbreviation you should know, because you rarely hear anyone say dilation and curettage, they say DNC, which is a procedure for the doctor to go in and sort of remove the fetus, instead of, I guess the other alternative is probably you can wait for your body to pass it, but and this is this is what would happen during both an elective abortion and oftentimes in a miscarriage. Oftentimes miscarriages are identified at a doctor's office when there's failure to find a heartbeat during an ultrasound. So not necessarily because the fetus has been passed out naturally. So usually a DNC procedure is done after the identification of a miscarriage. Uterine inertia is so inertia means, God, what is the physics definition of inertia? Like an unwillingness to move or change. Like if something's sitting still, it's really hard to get it going, and once it's going, it's hard to make it stop. That's my definition of inertia for you. So uterine inertia is a uterus that is not moving, and that won't move and is not contracting enough. And if you are in labor and your uterus is not doing its job and it's not contracting hard enough, then you're not going to be able to get that baby out. So in a hospital setting, there are drugs that can increase uterine contractions. Some diseases and conditions that affect the neonate, the newborn. Neonate literally means neo is new, nato meaning birth, so a newborn. Apnea, which is not breathing, having sleep apnea, having periods of not breathing. Respiratory distress syndrome, RDS, is if their lungs are not fully developed yet and kind of collapse on themselves. We talked about this a little bit in the chapter on the respiratory system, particularly if they're not producing enough surfactant. Fetal distress, this is during labor. If the heart rate drops, if the fetus is under stress due to blood pressure changes in the mother, etc. Jaundice, if the baby comes out very yellow, that is jaundice due to hyperbilirubinemia. Let's try that again. Hyperbilirubinemia. Bilirubin is actually yellow pigment that comes from red blood cells. And And so having too much of it causes jaundice. And it can be from a hemolysis reaction, particularly in women who are Rh negative and who have an women who are, Rh negative but have an Rh positive child. You can have this hemolysis, this hemolytic reaction, where the mothers, when their bloods mix, well, it's kind of confusing. So if it's a second child of the Rh negative mother, they can have this problem from having different blood types, essentially is the gist of it. Nowadays, again, in a hospital setting, most women who are Rh negative, I know here in Saranac Lake at the hospital, any Rh negative woman gets treated with Rogam, which is prevents this from happening, whether or not the baby is Rh positive. Meconium aspiration, that can be a labor complication where if the fetus is stressed, then sometimes they release meconium during labor, and then when they come out the birth canal, they actually aspirate that meconium, that stool, and it gets into the lungs and it's really sticky, and it can be dangerous and cause respiratory infection and respiratory breathing problems. So it needs to be sucked out. But it's apparently fairly rare. My sister, though, my mom always, it's funny, so my mom, when we were younger, she would tell us all the story, the story of our births in short, and she always told us that Alana, my littlest sister, what did she say, that she swallowed poop on the way out, and I remember we thought that was so funny, ah ha ha, you ate poop when you were a baby, and I was always confused because I never understood, well, was it her poop or was it my mom's poop? Whose poop are we talking about here? But I think what happened was it was a situation of meconium aspiration. I think she released meconium during labor, and they were worried that she may have aspirated it, and they had to suction her. So that's my sister's labor claim to fame. Nuchal cord is a condition where the umbilical cord is wrapped around the neck and can actually suffocate or choke the newborn. Some lab procedures or diagnostic procedures related to obstetrics and neonatology a little bit, I suppose. Different types of testing, of testing during pregnancy. So we talked a little bit about HCG, human chorionic gonadotropin, the hormone that you test for a pregnancy test, whether it be a pee stick, a urine test, or a blood test. That's the hormone that they're looking for, that you're testing for. Amniocentesis and chorionic villus sampling they used to be practiced more commonly. Now there's a lot of tests. There's a lot more blood tests that are available, so you don't have to do these much more invasive types of testing to test for chromosome anomalies, different types of congenital diseases that they can test for if they have a sample of the amniotic fluid or a sample of a chorionic villus. So before the placenta, it's the chorion, and it has these little finger-like structures that sort of, where's that? I'm going to go find a picture. Here we go. So you can see all these little finger-like projections. Maybe here is better. Okay, so taking one of those little fingers, the villi, would be a chorionic villus testing, and you can test for different diseases. Same thing with amniocentesis. Centesis, remember, is to puncture and then usually to withdraw fluid. So an amniocentesis is when the doctor goes in and punctures, literally with a needle and an ultrasound to see where he's going, goes in and withdraws a little bit of amniotic fluid to do a test. And it can be somewhat risky. Usually these tests are reserved for very high-risk pregnancies. Different radiological procedures. And these maybe should have gone in the gynecology part. So just looking at, using radiologic procedures to look at the uterus or the breasts, a mammography, a hysterosalpingography. What would that be? Hystero, the uterus, salpingo, the uterine tubes. So that would be a procedure to examine the uterus and uterine tubes. And ultrasonography is a procedure that takes a recording using it's a sonogram, so it uses sound. Sono means sound. So it actually bounces sound waves off, kind of like echolocation that bats use to figure out where they're going, and they bounce sounds off of things, and then they can kind of draw a map in their head. Same thing with what the machine does. It bounces sound waves off of the uterine fluids and can draw a picture. And now we've got this high-tech technology that you can actually draw these. You can get these three-dimensional images, which are just kind of amazing. My doctor actually has a 3D machine, but the pictures look nothing like this. They look just as unintelligible as the black and white stuff, if you ask me. But maybe he's just not as talented as this technician was. But it is really kind of amazing the level of detail that you can get now in ultrasound machines. So some other procedures, a colposcopy. I think I mentioned this actually in the last part of the lecture, to view the vagina with a scope. Colposcopy, used to look for cervical dysplasia. Cryosurgery, using cold. Cryosurgery, using cold, using like liquid nitrogen to freeze off genital warts or something, or even possibly to freeze off. I don't know if you can use it for cervical dysplasia or anything like that. I don't know if you can use it internally, but you can surely use it externally. Amniotomy would be a procedure to manually rupture the membranes to break somebody's water. Literally sticking a hook or some kind of sharp tool to rupture the amniotic membrane, usually to speed labor along if labor has stalled, or just to speed it along, or induce it is a way to induce labor that has stalled. Version I talked about is the procedure to take a woman, basically massage a woman's belly to get the baby to turn into the proper cephalic presentation. Epidural anesthesia is a form of anesthesia where drugs are, where the anesthetic drugs are inserted or delivered into the epidural space in the spinal column. And induction of labor is the inducing labor, to start labor using drugs or some manual technique like manually rupturing the membranes doing an amniotomy. APGAR score, this is a score that's given to newborns after they are born, like right after delivery. Doctors examine them real quick and give them a score. I think there's 4 or 5 different points. I'll look that up again. Basically just describes the health of the baby. Just obviously not going to test you on things that I have to double look up myself. Here we go. It assigns a score from 1 to 5, and it rates them on their heart rate, their respiratory rate, muscle tone, response to stimulation, and skin color. So the top score of 10 if they got 2 points. So that's what it is. What did I say? I said a score of 1 to 5. They get a score of 0 to 2 on 5 different points. So a top score of 10. So I don't know what the cutoff is for a good score, but the closer to 10, the better, and it just indicates how healthy the baby is right when they're born. Different techniques for assisted reproductive technologies. There's in vitro fertilization, which is basically taking some eggs extracted from a woman, sperm extracted from a man, mixing them together in a dish and letting them do their thing, and then taking a couple of fertilized eggs and implanting them back into a woman. Zygote intrafallopian transfer, or ZIFT, would be to actually manually transfer a zygote. So usually in vitro fertilization, usually they let the the zygote then divides a few times, and so they put the egg in, I think that was probably more close than you wanted to look at my face. Let's see if it says in here. They grow for 2 to 5 days in culture medium. So they are a little bit, no, I guess I was thinking that in IVF was a little bit more, the zygote was a little bit more mature, but it looks like in zygote intrafallopian transfer, that one's a little more mature. Either way, they're pretty much the same thing. It's pretty much egg and sperm in a dish, fertilize, let them divide a little bit, let them mature a little bit, pick a couple of healthy ones, and stick them back into either the uterus or the fallopian tube. And intracytoplasmic sperm injection is the one that's pictured here in the corner, where they actually this is especially common for if the male has fertility problems and maybe has a low sperm count or low sperm motility, and so his sperm are not doing the fertilizing that they're supposed to be doing naturally. You can actually take the sperm in a small needle and inject that needle into the egg and inject the sperm into the egg manually, and it forms a fertilized egg, a zygote, that can then develop and be transferred. This is my picture here of Octomom, who had 8 babies using in vitro fertilization. I think, if I remember correctly, she actually had, I think she had 6 eggs implanted and 2 of them split. I think that's what it was, but don't quote me on that. Some other surgical procedures: a hysterectomy, the surgical removal of the uterus. This can be due to some kind of uterine cancer. It can be a form of permanent contraception. It can be done because of severe endometriosis. There's a lot of causes or a lot of reasons to have a hysterectomy. Laparoscopy would be the pronunciation. Laparoscopy. A lot of surgeries nowadays are done laparoscopically, and hysterectomies can actually be done this way now too, where they go in and basically, so they don't have to cut a large opening to remove the organ. They cut a couple of small openings, and they stick in their tools, and their tools go in one, and a light goes in the other, and the little video connection goes in another, so they can actually see internally. They have a video screen that shows what is internally, where they are, and then they can actually do the surgery without having to completely open you up. A myomectomy would be removal of part of the muscle, the myometrium, in response to having a leiomyoma or leiomyosarcoma. Oophorectomy, oophoro, is a combining form that means ovary. Oophoro. Oo is a combining form that means egg. So, let's see if I can. Okay. O is egg, and O for O is ovary. Okay? So oophorectomy would be the removal of an ovary. A bilateral oophorectomy would be the removal of both ovaries. Salpingectomy is the surgical excision of the uterine tubes. So my aunt, who had 2 ectopic pregnancies, had to have 2 salpingectomies as well to remove those ectopic pregnancies. Tubal ligation is the term for the female version of a vasectomy, having her tubes tied. It's exactly the same thing as a vasectomy, except that it's the fallopian tube. So they cut a small portion of the fallopian tube out and then ligate them closed. And if you want to reverse that procedure, similar to a vasovasostomy, it would be a tubal anastomosis, which I think should be the name for I think vasovasostomy is a mouthful that's also a tubal ligation. So essentially taking the 2 tubes, ligating them back together. Or sorry, a tubal anastomosis, taking the 2 tubes and sewing them back together. Uterine suspension. So I didn't make it up. There's such a thing as a hysteropexy. I thought I was talking the truth. All right, so if the uterus is drooping, it's not standing upright, you can have a hysteropexy, a surgery to stick it in place. Colporrhaphy, I feel like I mentioned that like 3 times already, a procedure to suture the vagina if it's torn. And when I'm talking about the vagina, I'm talking about the inside, the walls of the vagina, particularly in the case of a cystocele or rectocele, when either the bladder or the rectum are herniating in. An episiotomy is a different sort of suturing the vagina. An episiotomy is a cutting of the vulva, or the perineum even, to sort of widen the vaginal introitus, widen the vaginal opening for the crowning for the baby's head, to prevent tearing, because tearing is more painful and leaves a bigger scar and is harder to suture than a clean cut scalpel cut. So it's done to prevent tearing. And a cesarean section is the cutting open of the abdomen and the uterus to pull out the baby if there are some kinds of complications with vaginal birth. A VBAC is a term you might hear in an OB ward, which means vaginal birth after C-section. So there's a lot of controversy about how safe it is, whether having a vaginal birth, that whether the uterus, after having a C-section, whether the uterus is then weakened or damaged by having been cut open and sutured back together, whether or not it can withstand a vaginal birth, or whether you just need to have all future births be C-section. So some hospitals allow VBACs and some do not. Saranac Lake, FYI, does not allow them. Surgical procedures of the breast. A lumpectomy is the removal of a lump or a tumor or a cyst in the breast tissue. Mammoplasty is any type of breast reshaping surgery. All right, plasty, reshaping. So there's breast augmentation, which is to augment, to supplement, increase in size. There's breast reduction, to decrease in size. And then there's a mastopexy, which is the fancy term for a boob lift, to fix the breasts in place. And then there's a mastectomy, which is the removal of the breast tissue, usually if in a case of not cervical cancer, of breast cancer. And here's a doctor showing you a silicone implant. So that is the end of chapter 13. The second half took significantly longer than the first, and I hope you made it through all of it. And if you have any questions, as always, feel free to contact me, to email me, and I hope that these lectures are not too painful to sit through, because they are painfully awkward to record, but it's my pleasure, and I hope that you find them helpful. And again, let me know if you need anything, email me or call me, and I'm happy to answer any questions. Otherwise, keep doing your MTI, your medical terminology interactive, particularly the ER, in addition to your homework. And hopefully I'll see you soon. Bye.